let me invite you to put down your pens and papers for a minute and just spend about a half hour thinking with me here this morning. It's a pleasure to be here to talk a little bit about a topic that I think is really important to all of us in the room. Let me see if I can be as fast as Dr. DeLatour. Very good. But let me just invite you to think with me for about a half hour about some of the big picture issues that we're all dealing with in this room, and then begin to boil that down to what it means for each one of us individually. This is a unique conference, one that I always enjoy coming to because we put all the people in the room, which makes for a very interesting kind of meeting, unlike anything else we normally do. And what's most interesting about the talk I'm going to give is this talk is things most of the people who are living with these conditions already know, but sometimes it's useful to preach to the choir. And I want to talk briefly about some of the key challenges we face in healthcare now, talk specifically about the increasing role of patients and their families in healthcare. The whole thing is changing dramatically. Talk a little bit about patient-centered care, which will be surprising to you all that scientists are discovering what you already know. And then talk about the concept of self-management and how we begin to actualize that and some of my thoughts for this particular group, this particular organizations, and talk then specifically about some strategies for both patients, families, and clinicians. So let me go through the background here pretty quickly. The first thing is that the picture is changing in terms of what kind of health care is problematic in this country. It's not true all over the world, but in this country, things are changing. What we see here, I don't know if you can read this or not, but this is a slide from about 2000 that looks at the indirect and direct cost of various diseases. And these are in billions of dollars, okay? We hear a lot of talk about AIDS. Well, that cost us about $22 billion, you know. We hear about stroke. Oh, that's about a $30 billion problem. Arthritis, everybody has that. That's about a $60 billion problem. You know, we hear about diabetes. But here we are out here. See where it says disability and rehab? That's all the conditions that are in this room. We're looking at costs that are approaching $170 billion. The only thing that costs more than us is heart disease, and we're hard pressing upon us, and this will probably cross over the next time this work is done in 2010. So chronic conditions are where all the money is going and where all the lives are being affected. We're doing a great job with a lot of the acute problems. So, and we also have the issue that people with chronic conditions are living longer, and they're not living in institutions. People are living in their homes, in the community. But the economic pressure is changing. More and more responsibility is being put on patients and their families. Things that we used to do in the hospital, you all are now doing at home. This is very clear. And that you all, as well as providers to a certain extent, are being held accountable for some of these outcomes. You know, you need to do a better job of taking care of yourself. You need to do a better job of this or that. We are all, those of us involved in the chronic condition business, are being held accountable for this increasingly. Traditionally, though, the majority of resources have been focused on acute care. You know, we hear a lot about acute care medicine, but not that much about long-term living with these conditions. But there is a growing recognition that with the increased role of people with conditions and their families having a technical responsibility, we have to begin to prepare them for this job. And we'll talk more about this work in a minute. Traditionally, we focused on what the doctor is going to do. You know, what's the doctor going to do? Well, as people in this room know who are involved with either living with a condition or are helping people live with a condition, is what the doctor does is important, but not the end, and not, in fact, most of the work being done. And we're going to talk about that in a minute. There's a lot of work involved in chronic conditions. There's what I call direct illness-related work. You have to identify providers. You got to make appointments. You have to take medicines. You have to follow through on PT, OT. You need to do a rehabilitation program. And then there's what I call the illness-related work. You got to fight the insurance company. You have to fight the managed care company. You got to find a way to get there. You have to see if is it accessible. Can I even get in the place I want to go to, whether it's the doctor, the movies, the stadium, or wherever it might be. You have to advocate. You got to come to this meeting, beat up on the doctors, tell them what they need to be doing. There's a lot of work to be done here. In addition to this, there's what I call the personal work. One has to kind of reconstitute oneself, come to a new understanding of who I am with this condition, who we are as a family with this kind of condition. And we have to accommodate to these changes. There's accommodation. A change is work. Anybody who has moved knows that change is work, whether that's emotional work or physical work. And there's the everyday work of doing ADLs take longer, taking a shower takes longer, getting dressed takes longer, getting to work takes longer, developing work and school options, what I call keeping up, covering up. These are all things that take a lot of work. There's a lot of work to accomplish here. The problem is that most of this work is invisible. No, except to you and the immediate people around you, the rest of people don't appreciate all the work that's being done here. There's not, in most cases, I mean, we hear a lot of talk about the Hopkins TM Center and so forth, but in fact of the matter is most people in most places don't walk into a facility and have a team waiting to take care of them. You got to find your own team. You got to find a neurologist, a primary care physician, an OT, people who understand your condition. You got to make that come together. And the environment is not particularly supportive. So we have a situation where the person who is doing most of the work, who is doing most of the healthcare work? It is not the physicians. I mean, Doug Kerr works pretty hard. Not that hard, really, but but some of us work pretty hard. Dr. DeLaTorre, she works very hard. I mean, we work 60, maybe 70 hours a week, but if you have MS, you have TM, you have one of these conditions, you are working, as we say at Hopkins, 24/7, 365. There's no day off. The people doing most of the work are the patients and their families, and we aren't doing a very good job teaching them to do the work they have to do. That's what this conference is so beautiful about. It's really taking time to take the class you need to take to do the work you have to do. We do not have this very well instituted yet in this country. So sometimes you feel like the picture's pretty bleak, gentlemen. The world's climate is changing, the mammals are being taken over, and we have the brain the size of a walnut. So you look upstate, sometimes you feel like this is all just overwhelming. There's all this work to be done. The cards are stacked against us. We're being taken over, and what are we going to do? But I think there are some things that we can do. And I'm going to talk about 3 big picture items and try to drill down on those with the time remaining. First of all, I think we need to change how we think about healthcare. I think we need to change our models of care, and I think we need to change our models of research too. But let me spend most of the time talking about the first 2. So we've already talked about that. People who have conditions and their families are taking a more active role. They're just being forced into it. Some people are coming kicking and dragging to the table. Some people are coming to the table of their own accord. The clinicians in the room must recognize who the real healthcare workers are, because it changes how we approach our interaction with them if we realize who's going to do most of the work here and whose, in fact, responsibility is it for the work. We need to acknowledge the work that patients and their families are doing and train them to do this work. And I think also, equally important, we need to recognize that people come to a condition, whether it's TM or DeVix or MS or whatever it is, they come to this condition with certain strengths and resilience and abilities, and we need to recognize those and foster them, rather than seeing people who have a condition as a sick person. This is a person with a problem, not a problematic person. And it's a big difference. So many of us are raised, born and bred focusing on pathology. We miss the health. The Institute of Medicine, catching up with this finally in 2001, said, we need to change how the healthcare system works. And one of the things they talked about safety and effectiveness, but the thing that I want to talk about today is one concept. They said there's 6 things we have to do, and one of them has this idea of patient-centeredness. And what patient-centeredness will talk about is the fact that if we move the focus of care from being focused on the provider, that is, what is convenient for me, what works for me, and how do I want to practice, and focus on what the patient actually needs, what their values and their preferences are, it changes things dramatically. It has profound implications for the way care is planned, delivered, and evaluated. That is, rather than asking doctors, are patients getting better, you ask patients, are you getting better? Outcomes measures in clinical trials have changed dramatically in the last 20 years. It used to be physician ratings of patient progress. That is almost never done anymore. It's all done either functional assessment or what patients think in terms of improvement. Patient-centered care focuses from the acute needs to the patient as a whole, focusing on integration of care, patient education, family involvement, and emotional support. And the interesting thing, as Dr. Ulatour knows as a member of the Institute of Medicine, knows that these are not ideas pulled out of the air. If the Institute of Medicine says it, they're saying it because there is data to say this is what you need to do to make a difference. So, patient-centered care focuses on respect for patients' values and preferences. We focus on coordinating and integrating care. We focus on empowerment, emotional support, and involvement of patients and their families. The key thing I want to make here is that empowering patients sounds good, but how do we make that real? How do you translate that to things we actually do? And what appears to be the case, based on the literature, is that to make patients feel and their families feel more empowered, we have to increase their self-efficacy. That is, their sense that I can handle this problem, a belief that I can handle this problem, and we need to activate them, that and have them be active members of the team. And we know that patient-centered care interventions improve outcomes only to the extent that they activate patients and improve their self-efficacy, and that these things happen when you have an informed, activated patient with a prepared, proactive team. That's the only way the outcome changes. If you develop teams and patients are not active members of that team, the outcome studies show doesn't make any difference. If you have active patients who have high levels of self-efficacy and they're not interacting with a proactive team, the outcomes don't change. You have to have both of those things to improve the outcomes. I mean, this is not rocket science, I don't think. So that we are discovering what patients have known. More involvement of the patient and family is required to change outcomes. So you have these guys working in the lab here saying, for crying out loud, gentlemen, that's us. Someone installed the one-way meter backwards. I mean, sometimes it takes the scientist a while to catch up to the patients. But we are finally there. Thank goodness. So some of the specific strategies to get to patient-centered care are these 3 strategies that have been shown to be effective. The first one is peer support and education. You all are doing that within the TMA. We see people getting together in groups, learning from one another. Peer support is becoming to be, I think, one of the key elements in the management of chronic conditions. The second piece is going to computerized-based health information that allows patients to access information at their own pace, at their own time, in the comfort of their own home, in a way that allows them to kind of digest it. And the final thing is training and self-management. I want to talk a little bit about training and self-management. Self-management is a tool and a philosophy. Self-management recognizes the fact that patients need to be active managers, that individuals bring strengths and resources and abilities to this problem. It changes the way clinicians interact with patients. That is, you begin to see yourself, if you're a clinician, as a consultant, as a trainer, as a teacher, rather than the person who has all the solutions. Because the fact is, in this situation, despite the progress that we're hearing about this meeting, clinicians do not have all the solutions. That is just not where we are today. Maybe in 10 years we'll be further along the road, but still we're never going to get there. It's the nature of life. We're not going to ever have all the answers. And it also recognizes that different people have different goals. I recall this one patient, just aside, is we had a patient on our rehabilitation unit some time ago, several years ago, who was a princess. I mean, she didn't think she was a princess. She actually was a princess from one of the Middle Eastern countries, and she came to the rehabilitation center with a retinue of people. She, literally had 10 people with her who attended to her needs. And the OTs were desperately trying to get her to feed herself, and she had a very high cervical injury, such that she could sometimes feed herself, but she ended up with 90% of the food here and 10% of the food in her mouth. And while she was making some progress, her injury was such that this was always, she would get to the point where maybe 50% of the food got up here and 50% of the food got here on her shirt, but that's where she was given her high injury. And the OTs, they called me because, as a psychologist, they called me for two reasons. The person is crying or they won't go to therapy. These are the two reasons they called me. So they said, this person won't go to OT. So I went in, and through the translators, I found out is she was not interested in feeding herself, because that is what servants are for. What she wanted to learn how to do was to sign her name on proclamations, because her job in her country was to go around and open up bridges and clinics and schools and do official functionings. They were saying, well, she has to learn to feed herself. And of course, to her, this was humiliating. She was never going to eat in public because it would be inappropriate for her role to be sitting there in a diamond-covered dress covered with food. It's just not going to happen. And once we figured out whose needs were going to, once the OTs realized this was the goal and who was in charge here, we moved ahead, and she had a very successful rehab eventually. But it took a while to figure that out. So in self-management, there are four essential components. We need to have knowledge. That's what we'll hear about this weekend. We need to develop our problem-solving abilities. We need to learn some skills Dr. DiLatorre was talking about that we have to learn to care for ourselves. And we need to monitor our condition. I mean, you hear all these talks, Dr. Greenberg, others talking about these various scales and so forth. Who's doing all that work? Well, the patients are monitoring all this stuff and giving feedback to their physician or their other therapist. We know, in fact, that self-management does work. And I just want to very briefly talk about, we just finished a very large randomized controlled trial. This is like I can pretend to be a scientist for a few minutes. Randomized controlled trial for people with limb loss, comparing 257 people who took our PALS course, Promoting Amputee Life Skills course, and people who were getting usual care plus going to a support group. And this is, as far as we know, the largest randomized clinical trial ever in limb loss. And we compared them. People participated in a 10-week self-management course where they learned about their condition, how to manage the problems, depression, anxiety, pain, manage their doctor more effectively, deal with their insurance company, work with their family, work with their employer more effectively. And what we found was, very quickly, is, interestingly enough, the majority of the PALS participants, approximately 80%, said that doing this self-management course was more important than anything else they'd ever received since they had their leg cut off, including an artificial leg. Because they said this taught them to work more effectively with their prosthetist, with their physician, with their physiatrist, to get the results they wanted to get. They rated it as being more important than a support group. Those people in the control condition, those people who did not get self-management, were 3 times more likely to meet the criteria for clinical depression. That is, people learning to be effective self-managers insulates you, protects you against depression. And these people had significant improvements in self-efficacy, illness intrusion, how much things interrupted their life, and in function. Their pain, unfortunately, did not improve. And these are people who are already out 6 years. These are experienced patients, so we're teaching the experienced. So we have a lot of work to do with TM. One of my agendas over the next 2 years, when we come back together in 2 years from now, I want to have a course for the TM people. And I want to put it online. And I think this is something we can do in the next 2 years. I think we have the data. I think you all have the infrastructure to the TMA. I think technology is to the point we can do this. I think we can do this in 2 years. And I think we can have a course that's relevant to people in this room, that's doable over the long haul. The problem with these we have in this room, it's hard to get groups together. But we can do it over distance learning. And I think that's a very reasonable goal we can set for the next 2 years. So, I think the other thing we need to do is think about how we think about healthcare. Is too much of our models now are pathology focused. About 3 minutes left. Are pathology focused. Learning about disease and what causes disease and cures, that's very important. But I would argue it's important, but not sufficient. We have to, when we're focusing only on pathology, it causes us to miss what is working with people, what skills, resources, abilities they have. And it emphasizes people as being victims. And that's one thing that's changed in the last 5 years. We've stopped using this kind of victim kind of terminology and talked more about people being survivors or being consumers. This is not just a change in words. It's a change in words mean things. It's a change in philosophy, it's a change of way of being. You know, we need to think about people as having a person who's an effective person who has a problem, who needs a team to assist them to do the work they have to do. If we think more in terms of health enhancement, we move away from just thinking about what's the germ, what's the pathology, how do I fix this deficit, how do I get back to baseline functioning with a passive participant, to thinking about what's this person's potential, what strengths do they build to this situation, how do we build on those strengths, as Dr. Dioto was talking about, the unaffected, if you will, side. The goal here is enhancing functioning and the person being an active manager. We need to have both of these going on simultaneously if we're really going to drive healthcare outcomes. So, we need to expand our focus from just eliminating pathology to enhancing functioning and well-being. It's a change of how we think and what the goals are. Or to put it slightly different, treatment is not just fixing what is broken, it is nurturing what is best. And if all we're doing is fixing what is broken, that is not enough. Because too often we cannot fix what is broken, but we can nurture what is best. So, a few comments on becoming a successful self-manager right today. First of all, recognize who has the responsibility. It's your condition, it's your illness, it's your family. That's how it is. Just get over with it and get on with it and begin to work with that way of doing it. Get education and training. We're talking to the choir here a little bit, but keep learning, keep learning, keep learning. You need to set, as Dr. Dioto was talking about, you need some short-term goals, you need long-term goals. So this is what I want to accomplish this month. I want to find a gym that's accessible and get back to the gym. So that in 6 months from now, I can do this. I can go to Disneyland, do that vacation, and really enjoy those rides. Be keenly aware of what your strengths and abilities are. You know, people come to see me, as some people in this room may know. I mean, I'm always asking people, well, okay, what's going on with you? People tell me this litany of things, and I say, okay, tell me 3 things that are going right. What do you think your strengths are? A rehabilitation assessment that does not include what the person's assets and strengths are is not a rehabilitation assessment in my mind. That is not rehabilitation. We're only focusing on deficits. Develop a support system. You need to have other people who know what you're trying to do. Advocating for ourselves and others. And the final thing is everyone has to have a purpose. A big study was done by Ed Diener and his group at the University of Illinois looking at quality of life. And there are two things that repeatedly show up in the psychological literature about people who, if you will, are living well with any kind of chronic condition or disability. They have two things that differentiate them. They are flexible. They can see many different ways to do anything. And the other thing is they have a purpose. They have something they're trying to accomplish in their life. I'm looking to raise my children, go back to work. The point is not what the goal is, but they have something that's meaningful, that they're trying to accomplish in the course of their life. If you don't have that, it's hard to stay hopeful and to be engaged. So we want to prepare for healthcare visits, know what you want, get routine tests ahead of time, so when you go to the visit with the physician, with the clinician, you can spend your time talking about the results of the test. Nothing is more useless to come person and say, well, go get these results and I'll call you later. It's better to get the results ahead of time. You have an appointment coming up, call the office and say, are there any tests you want me to get before I come? That way the results are in the chart when you show up and you can make decisions. Focus on key issues. Write out your questions. If you have more than 5 questions, you have to prioritize because you may only get to 3. So results have shown if you have more than 5 questions, you won't get beyond that. You have to prioritize them because you won't get beyond 5 questions. Develop a team and a system for your records. Nothing is better than when a patient comes in with a nice binder and says, okay, here's my medications, here's my situation, this is the thing. Now we can get down and make decisions. We can make decisions. Teach your doctor what you need and be blunt. I don't mean be angry, be mean. I mean be blunt, be straightforward. This is my situation. Don't beat around a bush. Don't worry about hurting their feelings. If you worry about hurting their feelings, you probably should find somebody else to work with. For those of us clinicians in the audience, we need to respect the work that's being done by people with chronic conditions. They're doing the work. We need to acknowledge the fact that patients and families are team members and are the leader of the team. We need to respond to their values and preferences and needs, recognize their strengths and resources, and we need to think about in terms of health enhancement, not just pathology treating. I would suggest that every visit you have with a patient, a portion of that visit should be spent doing education and training. Stephen Covey calls this sharpening the saw, I think, in one of the 7 values or habits. He spent some time teaching other people what they need to do to help you do what you need to do. So if you're a clinician, spend a portion of the time teaching your patients. Don't forget to attend to pain and comfort issues. This is a key issue in patient-centered care, and we need to address the emotional component in every visit. Not, how are you feeling from pain perspective, but how is your life going? If a physician asks somebody how are you feeling, research shows the patient responds with a physical description. If a physician wants to know someone's emotional tone, you need to ask questions such as, how is your life going other than for your illness? You need to cause the patient to think broadly. We need to make decisions based on patient preferences. We need to think in terms of being consultants. And we need to think that even though this is only one of my many patients, this is this person's only life. That's what separates, in my mind, a great clinician from a technocrat. When they're with somebody and when you're with them, you're the only person that exists at that moment. If you're helping a child with this kind of condition, you need to model a proactive behavior with the kids. As the kids get older, give them more and more responsibility. I would argue by the time a patient, if you have an adolescent with a chronic condition, they should have time by themselves with the provider. By the time they're 15, 16 years old, they need their own time, even if you come in for a portion of the visits. This is a big problem some of the times. I'm going to skip this right now. So the take-home message is the patients and families are the essential workers. Physicians and other members need to support this team. And the burden is shifting, if you will, from cure to health enhancement. That's what we need to focus on, and we need to get this TM self-management program up and running 2 years from now. Thank you all very much. So we need to move from disease to creating health.